Hello, everybody. Thank you again for joining. I think this is it. This is the last chapter for Phase 1 of Education 4.0. So we'll cover the hospital pharmacy. Another two-parter. Split it up. All right, let's get into it. So usually starting off, most technicians will start off in retail. And once they have about 1 or 2 years experience, get their foot in the door, start their network, then usually that's when hospital jobs will open up. So it's very rare that a brand new tech will go directly into a hospital, but it has happened. So in some states, you're required to be certified before you can even work in a hospital. So you have to take the exam, PTCB, or the EXCPT to qualify. And in some states, they allow for up to 5 technicians for every pharmacist. So for the pharmacist to tech ratio, it's expanded if they are certified. And in some states, you have tech, check, tech. So that means one technician will fill the drug order, another technician will then check them, and then it goes to the patient without even the pharmacist. So hopefully that spreads to the other states, giving more opportunities to technicians. So in the hospital, patients with the same conditions are usually grouped together, like cancer ward, surgery, cardiac, pediatrics, etc. And there's usually a nursing station where the main communication center is. And then the patients will visit other areas of the hospital to get procedures done. We call those ancillary areas. So to get x-rays, the emergency department, catheterization, right? All those areas may still require medication. Let's go to some of the units. So we have the coronary care unit. So that's for heart conditions. Not the emergency room, it's an entire emergency department. We have the intensive care unit. So it's usually a 1-to-2 ratio for every nurse. They're only servicing, caring for 2 patients. The NICU, the N stands for neonatal. So that is a newborn baby. OBGYN. And then we have the operating room. The PACU. So after surgery, we need to get them out of anesthesia. So that's going to be the post anesthesia care unit. And we deal with a lot of nausea and vomiting as people come out of general anesthesia. And then before we put them back up on the floors, we may have to keep them to stabilize them in the surgical intensive care unit. So right after surgery, maybe they need a little more specialized care before they go back up on the floors. The healthcare team. So make sure you're familiar with these abbreviations, who can write prescriptions, whose responsibility to do what. So we have registered pharmacists and a PharmD. So the old education requirement was a 4-year degree, Bachelor of Science in pharmacy. Now it's a 6-year degree to get your PharmD. So a little extra training. Once you get your degree, then you need to register with the state. So whichever state you want to practice, you must be registered. And most pharmacists, if they're registered in one state and another, they tend to keep their license. It's really hard to then try to get re-registered. It's better to just keep the standing. Same thing with the technician. So if you get your license in California, might as well keep it in good standing. You never know when you might come back. Name the following hospital units. The ED, not just a room, but the entire department. The NICU, N is for neonatal, intensive care unit. Anesthesia, so afterwards, that is going to be the post-anesthesia care unit. So sometimes we'll just abbreviate it. ED, the NICU, the PACU. Make sure you know what the other hospital staff are referring to. Identify the following healthcare team members. So the PA, those are the physician's assistants. LPNs in California, I think they call them LVNs, licensed vocational nurse. So in this case, licensed practical nurse. PharmD, doctor of pharmacy, now a 6-year degree. Most pharmacists, we just refer to them by their first name, very informal. Technician's role in the hospital. So here at the counter, you're not going to have a lot of patient interaction. Actually, you're going to have almost zero patient interaction. You're mostly going to be interacting with other members of the healthcare staff. The outpatient pharmacy is located usually in the lobby area where it's more accessible to patients. So the central pharmacy is usually out of the way. The filling system in the hospital is for a 24-hour supply. So they also call that the unit dose system, the cart fill, patient cassette, patient drawer. So if you ever hear those terms, it's synonymous. So today, you got to fill for tomorrow. Everything that the patient will take tomorrow, you got to fill today. And today, you got to check yesterday's. So anything that they didn't use yesterday, you got to take back to the pharmacy and credit. So that's the old traditional unit dose fill. But we still fill in the hospital for a 24-hour supply. Order and processing, most of the time it's going to be the pharmacist entering the orders. That's because in the hospital, all orders need to be validated by the pharmacist. So if the tech entered the order, the pharmacist would then have to check the order, and then once the drug is filled, the pharmacist will have to check it again. So this is to prevent a triple check. Right? However, the tech can update the information. Techs can't interpret the data, however. Monitoring drug therapy. So the anticoagulant patients, diabetic patients, we can collect the data, enter it in for the patient, and the physician will determine if there's any changes needed. A narcotic technician, so in the hospital, you're going to need 100% accuracy. If not, there's going to be documentation required. So all drugs are in a secure dispensing system. So it records who got access to the drugs, previous to and after. Delivery, a lot of times you don't need to be a technician. You can be a clerk or a pharmacy helper or a pharmacy assistant, and you can deliver meds. Just drop off meds to the appropriate area, put it in the inbox, and you can also pick up drugs that are in the outbox, things that are meant to be sent back to the pharmacy. A lot of automation in pharmacy. So there's automation in unit dosing, cart fill, even IVs. There's automation for communication. You'll get a lot of warnings, stockouts as well. QA, a technician can conduct the QA training for the staff. Investigational drug services. So if a pharmaceutical company is in clinical trials, they'll need to enroll patients. And one way to enroll patients is at the hospital. So a technician can be paid by the drug company to enroll patients, collect data, and even sometimes administer and mix the drug as well. A little bit more compounding in hospital than in retail. And a lot of times you'll make bulk formulations. For example, a commonly used ointment or cream in the hospital, you might make a big batch and divide it among smaller dosage that you can then just label as needed. So this is called anticipatory compounding, which is perfectly fine as long as you get a prescription for it and then you have it ready to go. Repackaging unit dose. So if you have a bottle of 100, in the unit dose system, you got to put them 1 tablet per package, 1 capsule per package. So there's a whole rule on what you can repackage and what you can give as the expiration date now that it has been repackaged. Training. So this definitely can be a technician that does the staff training, run the seminars. Work in the IV room, definitely. So since USP 797 implementation, a lot more requirements of the hospital. They need hoods, they need a clean room, they need trained staff, and it gets very complex. For chemo, still need to follow chapter 800 for IV compounds of hazardous substances. Inventory control. So everything is computerized, especially for narcotics. So every drawer will record who gained access, beginning counts, ending counts, and if there's any discrepancies, those discrepancies will need to be reconciled. Supervisor, yeah. So to make the schedule, train technicians, evaluate technician, it doesn't have to be a pharmacist. A hospital can save substantial amount of money by hiring a technician to supervise the other technicians. In modern and larger hospitals, there'll be satellite pharmacies that usually service specialty areas and will have different drugs. For example, oncology, the chemo meds will be different. Labor and delivery, those medications, and even the emergency department, those drugs will have different needs. The outpatient works just like a retail, and it's usually in an easy accessible area, usually the lobby. So when patients are discharged, they're usually given a prescription, usually enough for a few days, 3 to 5 days of medication before they see their primary care physician. So it's not intended to be the prescription that they refill. It's just enough to continue what they were given in the hospital until the doctor determines what's the best course of action for them. So a lot of times the outpatient pharmacy will do the counseling in the patient's room. They'll have the drugs filled, ready for them to go. So providing great service to the patient. And it gets them on this. All right, definitions. Cart fill. Which of the following describes the cart fill? AKA unit dose, AKA 24 hours, patient cassette, patient drawer. The only downside is you gotta credit the patient any unused medication. Order processing. That is done by, So not necessarily entering drug orders because they'll need to be validated by the pharmacist, but updating profiles, allergies, labs, just not interpreting the data. The inventory technician. So yeah, they'll handle recalls and drug shortages. For recalls, just make sure you document all your actions. IV clean room, they make, well, there you go, intravenous medication. So the question and the answer were given. And then investigational new drug, prepare study meds for pharmaceutical companies. So enroll patients, collect data, mix, and deliver. So most hospitals will have a central pharmacy, may or may not be 24 hours. So in smaller hospitals, they might close in the midnight hours. No problem, they'll just get remote support electronically from a hospital that might be open 24 hours. And they'll make those drugs accessible through them via the automated dispensing machine, kind of like a Pyxis. So that's just like a vending machine for the nurses. There'll be a computer screen, a keyboard, and a bunch of drawers. So they'll enter in the patient info, which drug they want. The drawer will pop out, giving them access to that medication, and they'll pull the med. So this is what most places are turning to instead of filling drugs in the patient's cassette. So for anything PRN, they'll fill it in the automated dispensing machine, and when the patient needs it, the nurse will go to the machine and pull the drug. So instead of crediting the patient every day. For satellite pharmacies, your hospital may or may not have any. For larger and modern hospitals, they'll probably have a pharmacy on every floor just to expedite drug therapy. And then outpatient acts just like retail. Organization of medication, so alphabetically by generic names in most pharmacies, most hospital pharmacies. And just like retail, how they're grouped by route, here they're grouped by similar to their dosage forms. So all the powders will be in one area, all the IV vials in one area, topical solutions. So if it's not on the shelves, check the fridge or the freezer. For compounding, a little bit more. So make sure you just follow the recipe and document on your compounding log. For reconstitution, powders, so like amoxicillin. So first measure out the diluent amount. And then second, you're just going to add a half. Third, shake well. And then fourth, you're going to add the remaining half. Probably want to shake again. And then since you reconstituted, you'll need to affix the appropriate expiration date. So if it's dry, it's good up to the manufacturer's expiration date. However, since you reconstitute it, make sure you read the label and affix the new expiration date. Formulary. So formulary is a list of drugs. So in the hospital, it's the list of drugs that you can order and use. So the P&T committee, they come up with this list and they review it annually. They remove some, add some turn to generic, some are unavailable, so they'll always update it. If you have a closed formulary, that's it. You can't get anything outside of it. However, for drugs that are expensive or dangerous, you may not want to have too much around. So just send a request, and if the physician must have it and justify it, most likely you'll have the approval to order it. Therapeutic interchange. So a lot of drugs of the same class work very similarly. So these are a list of H2 antagonists to reduce acid in the GI tract. So we have cimetidine, famotidine, right? So these drugs, if your doctor orders it, it'll just be converted to Zantac, ranitidine. Right? So as long as they follow the protocol, pretty simple switch. So these are for PO, and then they'll do the same here for any IV orders. Right? That's to help save costs, reduce costs, and prevent any errors. All right, that concludes part one of the hospital pharmacy. We'll talk more on responding to codes and other additional technician function in part two. So that means we have one lecture left for phase one of Education 4.0. So before we enter into phase two, I got a big announcement for you guys, so stay tuned for that. I'll schedule probably a live session, and if you miss the live section, it'll be recorded for you on the channel. Thanks again, and I'll see you next time.